So let's get rolling. So I'd like to welcome everyone to Inside the Doctor's Lounge. If you're not familiar with what happens inside a doctor's lounge, let me kind of brief you. A doctor's lounge is a place where physicians and other medical professionals can gather and have honest, frank discussions without fear of any type of repercussions, I should say. And it's a place where you can have honest dialogue. And this is what it's all about. And each week we cover different topics. And today we're also very fortunate to have a special guest who I'll introduce in a second. First, I'd like to introduce my colleagues with MD Coaches, Dr. Randy Cook, Dr. Rick Zollinger, the CEO of MD Coaches, Rhonda Crow, and our guest today is Dr. Edwin Leap. Ed is wears multiple hats. I guess we all do, but he's really got some interesting background to share with us today. And, you know, we'll do a little hatchet job of an introduction, but he's been in the emergency medical field for over 24 years. But he's got a website too that's got a lot of interesting content because it really reflects his passion as something beyond a physician. He's a communicator, whether it's through written word or visual or just basically what we're doing here today. I think we're really fortunate to have him. And, you know, with that, I'd kind of like to kind of get into this topic, and I'm going to put Ed in the hot seat right away. Because, you know, Ed, you've been in the ER for a long time. And, you know, one of the topics that we've had here in the lounge recurring is, you know, we've seen over the course of our careers this increased number of hospital administrators. And, you know, at one time, physicians kind of ran things, you know, directed the care. And over the past several years, we've seen this reduction, let's say, in overall number of physicians. And we've seen more mid-levels emerging.
Sure.
And, you know, my concern is, yeah, these are people who are generally qualified and they work alongside physicians, but we're kind of getting this sense that there's an ulterior motive here in cranking out more of these mid-levels, whether it's PAs or nurse practitioners.
Right.
We seem that we are, as physicians, we feel like we are becoming commodities, which we are.
Mm-hmm. Absolutely.
And I just want to kind of get this going by, in your years of, you know, in the emergency departments where you've practiced, I know you travel too. Have you seen this increased number of mid-levels, and do you sense any impact in the overall quality of care as a result?
This is a topic of great concern to a lot of physicians, as you know. And so just to give you an example from my personal career trajectory, when I finished residency in 1993, I joined a group of 4 other physicians, all physician group in a small town in South Carolina, and we ran the contract. We were contracted with the hospital. We were not employees. We were our own corporation. I stayed there for 20 years, and then for various reasons I left. But about that time, it was taken over by a larger corporation, as so many are now. Along the way, we did, I think maybe 10 years in, add a nurse practitioner. And this nurse practitioner was one that we had known for a very long time as a nurse with impeccable experience, who we trusted all the time. She'd been a nurse for 15 years by then or more, and she went to nurse practitioner school, and you knew that she would always do the right thing. She was diligent, she was cautious, no question. We added a couple of physician assistants, and then a couple of those were very, very good, and a couple were weak. And then we added nurse practitioners later, and some were good and some were bad. But over time, what we see, and then after I left there, what I see other places is, as volumes climb, and they do until recently with COVID, right? I mean, our ER volumes are down about 60% now. But as volumes climb, administrations look at these numbers and go, why would I put a physician there to cover the volume when I can put an advanced practitioner? It'll cost me less. And interestingly, their insurance is less. And I think that's one of the big keys, that their malpractice is less. Although in many instances, they're seeing exactly the same patients. And so we do feel commoditized. And to give you an example of how far that's advanced a pace, there is a hospital I know of in Iowa where the emergency department physicians have all been replaced and nurse practitioners have put in their place. It's a rural hospital in Iowa. So the physicians are not needed anymore. They put nurse practitioners there. I see this advancing in the rural world where I tend to work, as people will say, well, and physicians will say this, well, we really don't want to put a doctor out there. We'll have some nurse practitioners or PAs, and we'll have a central location. They can call us and we'll video conference in and see what they're doing. Now, that to me is reprehensible. I think, and I've been in hospitals where this has happened, where they've tried to run codes by telehealth or something like that. It's terrible. But I do see over time this increasing commoditization, and I can tell because I look at job ads. And you used to see 20,000 volume per year in the emergency department, single coverage with mid-level. Okay, so one physician for 12 hours, the next physician for 12-hour nights, and the mid-level crosses over. And by the way, they don't like the term mid-level. I'm sure you're aware of that. The advanced practitioner is probably the more politically correct term.
I don't really care about political correctness, just so you know.
Yeah, but then I'll see a volume that says 25,000 single coverage with advanced practitioner. All right. Then I'll see 30,000 volume with advanced practitioner, and then maybe overnight advanced practitioner. 35,000 with 2 advanced practitioners. The number of physicians stays the same. So in my experience, what's happening in the last place I worked intensely with these folks, the nurse practitioners, or sorry, the PAs at the time, were actually seeing some pretty sick patients because there was only one physician. So if I had 6 or 7 chest pains going at one time, and another person came in with pneumonia, I can only see so many sick people at one time. It would just by default fall over this person. All right. Add to that the fact that as we're being asked to use them in our work, we're also asked to sign off on their charts. All right. So that's theoretically good because it means I'm supervising them. But the point of the reality is most of us don't have time to go and personally see all those physicians, or indeed personally review all those charts. We just don't. So at the end of the day, we all know we're lucky to finish our own charts, right? And if you wanted to go back and look at the rest of the charts, no hospital today will pay you to do that. You're not going to get money to come back and do chart review so that you can try and sign the charts. They'll say that's fine, just sign it, right? And I wrote a post about this one time, just sign the chart, everybody's doing it. And yet there's a peril to that. And physicians are being sued now, and successfully, because they signed a chart or because they were actually unknown to them, the supervising physician in a hospital for a mid-level or APP at another location. It was in their contract and they didn't know it. So this APP over here does something they're sued for because their name's on the chart. They weren't even physically present with them. So really in some ways we're being commoditized in terms of our work, but also in terms of our authority and simply our signature. Sometimes I go to work, I feel like I'm paid to sign charts, just to sign things.
Oh, of course you are. And that's a big part of it. And it's, and kind of where I'm going with this too is what I'm seeing is we're kind of at the intersection now of we're kind of flooding the market with these advanced practitioners, mid-levels, however we want to call them. And it's not to disparage anybody. It's like after a while you get caught up in terminology.
Sure.
It is what it is. What I'm seeing is that as we're getting these people coming out, their experience is limited.
Yep.
And with that comes a lack of critical thinking potentially too, because they're being trained in this whole electronic health record era too. Where their back can be to the patient as they're entering their notes, and
right.
Here's that monster again, the EMR being part of all this too, mining all this silly data, and
right.
Quality of care is, in my opinion, certainly is suspect now.
It seems like to me, like if I talk about Randy and I, when I worked with my PAs, and you specifically, Ed, were working with them in your ER department, and you knew that person, like you said, that's a whole different thing. But this thing, if the hospitals want to save money on malpractice and that, and put them under that umbrella, then either they have to eliminate the physician and say, okay, you're not in that loop for medical legal stuff, or they're going to hire physicians to only work, you just cover those 10 nurse practitioners. That's your job, and sign off. We pay you X number of dollars a year. I don't know. I said earlier to these guys that I learned that the electronic records were, I thought in 10, 15 years ago, I said, oh, that's going to be to our benefit as physicians. And the reality is everybody goes in from 11 to 7 and pushes repopulate. 7 to 3, repopulate. There's no subjective note put in the chart anymore. So if you go back and review a chart, you can't find anything. It all says everything was wonderful.
Right.
So yeah, I don't know. I understand the rural, like when you're talking about rural, the Smokies or being out west, it makes great sense. I'm not sure in a metropolitan area that the hospitals I care whether they're saving money by hiring the nurse practitioners.
Yeah, that cut and paste that you just made me think of something, Rick. I've gotten on patients with ischemic gangrene, basically no flow to their lower extremity. But I keep going back over the chart, day after day, week after week. Oh, palpable pulses, and
Right.
that's a classic example. Just a simple little example. But
well,
anyway.
That's a classic resident story where the chairman comes in and says, well, what were the pulses? Say 2 plus and equal on both legs. And he said, even in that amputated leg, it was 2 plus and equal.
Yeah.
I think that also one of the dangers here is that there is this enormous pressure to chart maximally, right? So the hospitals want every chart coded up to a 5 or whatever. Now, I'm very diligent about this. I take things out of charts, out of templates all the time because I didn't do them. If you come into me with a forehead laceration and you're a young kid, I'm not going to listen to your heart and lungs. I'm not going to pretend that I did because I don't need to, right? But I think every chart is done that way, and particularly in that world. But I shouldn't even crack on APPs on this. Physicians do this all the time. I had a partner who did this, and they would always chart everything maximally, but it was all templated, right? So you're right. You could find errors every time because they didn't do that, right? I mean, so it'll say, no murmurs, gallops, rubs, or thrills. Really? Did you really listen?
Yeah, level 5 on everybody.
Yeah, no,
absolutely.
And that's problematic. Personally, I think that's unethical. But now hospitals want that because they can charge up in point of fact.
It's going on in private practices too. I will tell you that I worked in a group that was same thing. It's like, wait, you guys spend about 5 minutes. You walk in, you listen to the heart and lungs, and you're out the door, and you're billing for a level 5.
Right.
Anyway,
it's terrible.
What is the difference, fellas, between the way a nurse practitioner could be used in rural areas versus a PA? What's the difference?
Well, it depends. Some states actually give much more leeway to nurse practitioners than PAs, and I think that's and Rhonda, maybe you can answer this. I think some of that's really about the influence of the nursing boards in the system, maybe, because that's educationally exactly right. they should be able to do the same things. And I would argue, I think that first of all, back up and say I think they all have their role as long as that role is appropriate and well delineated for what they're trained to do. But the didactic training of PAs is much more rigorous. That first year is like first and second year medical school combined. And I also would make a difference in that there are brick and mortar nurse practitioner schools, which I think are probably much better. And there used to be a lot more of that. The problem is we've moved into an online education world. And so you have people who have I've looked at their curricula. I've looked at the schoolwork they're doing when they're in the ED and they have time off and they're sitting between patients. It's not that germane to patient care, and that's a problem. There's only like one online PA school, and I don't like that either. So I think when you talk about commoditization, and we'll get back to the rural question, the schools are trying to churn out as many as they can because it's revenue, right? And these students are being sold a bill of goods. They're being told, if you have your RN, we'll get you through the NP school. I've seen this without a BSN. We'll get you through NP school, and you'll be the same as a physician, and that's unfair to them.
Yeah,
it's dangerous language too.
Yeah, they're even pushing the. Yeah. I'm sorry. Down here they're even pushing now the doctorate in nursing too. So now you can be Dr. so and so, but you're still a nurse. Okay, you're not an MD, but that's the latest wrinkle in this.
And I think that would be there might be a role for that if you have advanced didactics and if you have far more bedside education. Now, here's the interesting contrast, and here's another thing we could use in rural areas. If you're a physician and you finish medical school and do an internship, nobody will hire you because you're not specialty trained. Now, in the old days, what did we do? A lot of primary care doctors did an internship and started practice, right? And they did, especially in rural areas. Well, now we would never allow that because you're not a licensed physician. You're not fully licensed. You're not fully trained with your residency. But we'll say, we'll take a PA and put them out there because they can do the same job. Well, they finished a fraction of your education. So why don't we take these young physicians, even those who, maybe some of them who can't get residencies now because of the lack of residency slots, there's a big move to let them, they call them graduate physicians, let them work. Why not take them to those rural areas? Because they have already got about 6,000 clinical hours plus 2 years of didactics. I mean, that's an important.
Well, do they do that with the intention? Some of them, like the old plan where they pay off their student debt.
That's not been done yet, I don't think, but I think that should be the goal. The military does this. If you finish your internship, you do operational medicine for a couple of years, you're a flight surgeon or undersea medicine, then they'll psych you back to your residency, right? I mean, but I think there is a role for those folks in rural areas. The interesting thing is, if you look at rates of practice, nurse practitioners, and I don't know about the numbers of PAs, I suspect it's the same. The argument is we'll fill in for the lack of primary care in rural areas, but they aren't going there. Statistically, they're going to cities. So the rural areas are not really getting served by that model. Maybe it will, and it may happen as the jobs dry up in the city. Rhonda, do you see that there's an increasingly tight market for those folks?
Well, not. I agree with you. I think they're more so attracted to the larger areas because they can pull a greater amount of practice and experience, but also I think you've got health systems that are doing exactly what you were talking about, trying to be more economical in how they deliver care. And when you first set up your scenario there, Ed, you did a great job. You actually touched on many points that set us up here. What went through my mind was, I just wonder how many of these programs in trying to come up with the answer for both being economical but providing safe care that is having everybody stay in their lane, how many times were there physicians that were brought in to talk about that, to discuss, here's where we are, here's what the concern is, here's where the business issue is, how can we work together so that everybody's in their lane and staying together? My guess would be zero. We're pulled into those conversations, and that's to me, that's where the problem lies.
Sure.
In addition to that, I like the phrase "stay in your lane." It doesn't mean that you don't have the ability to grow and to advance your skills and your techniques, because as the sole nurse here, I'm all for nurses continuing to develop and growing their skill set, but it has to be in harmony, orchestrated with their colleagues. It has to be with the physician. And I don't see that happening. I see these roles and the way we're going about training these individuals, it's all business oriented. It's all business related to meet an economic standard. And that's not keeping the patient centric. That's really where my concern has been.
Sure.
I'll throw something else out there too, and I'm probably going to catch some flack for this, but I think it's kind of breeding some contempt as well between, some of the nurses, let's say, who are going for their advanced degrees, just saying, I'm as good as this doctor or whatever. And unconsciously, that's a dangerous thing, this competitive thing. It's like you just said, Ron, we're supposed to be working together. Stay in your lane, respect each other's training and what we all bring to the table. And unfortunately, I think that's going to get blurred more and more too.
What else is and this isn't being sexist, this is just a statement that the medical schools, like the University of North Carolina now, is I think 63% female graduates. And there's just a different outlook. I don't know what it is. I mean, I feel like women are more empathetic, more willing to negotiate than men, at least in my era. And I think that'll reflect on how it works. I think the system, I don't know how that'll happen, but that's a sea change in medicine.
Folks, I think we're coming very close to something that gives me the most concern. And interestingly, to bring Shakespeare into the picture, it appears to me that the past has become prologue. If you look back at the development of the practice of medicine in this country around the turn of the 19th century into the 20th century, if you wanted to be a physician, you had to do nothing more than have enough cash that you could go and pay a preceptor who had decided he was going to be in the business of creating physicians, spend some time with that individual, and when that preceptor declared you fit to practice, you could go out and hang up your own shingle. Now that was really, relatively speaking, not that long ago in the early 1900s. Because of the Flexner report, which examined the way we educated physicians in this country, it became apparent that in Europe, they were doing it a lot better. They had the system that our system is currently based on. And through a lot of effort that began at Johns Hopkins University, we began to train physicians the way they are trained now. And it worked like a charm to the point that our medical schools actually became better than, or at least as good as, and in many cases better than, the medical schools in Europe. What appears to me to be what we're experiencing is a new era where people can train individuals to practice medicine by their own standards. And interestingly enough, our own specialty boards have either been unwilling or unable to define scope of practice in such a way that we know exactly who is qualified to do what. So what I'm seeing is a situation where people can actually go and pay for a quote medical education that is regulated by no one and be licensed to go into the community and do things that they may or may not be qualified to do, because nobody has been able to define where one person's responsibility ends and another person's begin. And this has actually been it's been seen. The specialty boards in this country have tried to face this, particularly the American Board of Family Practice, and they finally said, oh, well, we can't do this. We're going to leave it up to the states. And what did the states do? They turned right around and said, oh, we're going to leave it up to the specialty boards. So there's nobody to stand up and say, I've taken a big look at this like Dr. Flexner did back in the early 20th century. Nobody has been able to examine the way that different individuals are practicing. We need to have a systematic examination of the system again so that we can make sure that we know what good education looks like and how to determine if somebody is qualified to do whatever it is they're doing.
And I think it needs to be a neutral body. You know, I don't think it should be done by physicians or by nurse practitioners or by PAs, just like the Flexner report. And I actually wrote about this for Medpage a couple weeks ago. I said we need to look at let's look at naturopaths. Let's look at all these people out there doing things and say, who's allowed to do what? Right now we have pharmacists who are pressing for the right to practice and prescribe.
Absolutely.
So come on. I mean, you're right. We've circled all the way back again, and I think ultimately. We need to, of course, reemphasize a couple points. People who are doing this as APPs, many of them are very good as long as they know their limitations. And I've corresponded with and seen comments from, for instance, nurse practitioners who went to medical school who said, wow, there was a lot I didn't know, you know. Mm-hmm. And when I wrote about this on Medpage, a lot of the comments you'd think they'd be very toxic, but I tried to take a very nuanced approach. And a lot of people were saying, you know, yeah, I'm concerned about this. And I think it's unfair for us to put these APPs out there on the promise that they're safe to do all the things they think they're safe to do, because they're going to get ambushed, they're going to get lawsuits, they're going to get in trouble, they're going to get over their head, and they're going to feel enormous guilt over mistakes they made, things that we would have learned in medical school and would have been, intern year one thing you would know better than to do, and they weren't educated that because they were told, oh, this is fine. You'll figure this out on your own. If you look at their message boards, I've seen some of them. It's kind of terrifying. What do you think the CKG shows? And it's obviously an MI or things like that. And that it's not that they aren't good people. It's that they're being sold a bill of goods by the schools.
Absolutely.
And this is yeah. So I didn't mean to jump on you. This is like part of my concern is, you know, we're cranking these professionals out, and yet, as like you said, they could be potentially in over their head, and who's going to suffer? And we're going to see more of this. And guess what? Then watch their malpractice start going up too. And you know, all these things are going to start to happen. Anyway, forgive me. I didn't mean to jump on as you were finishing up your point there.
I think the other problem is some of these schools are co-located with medical schools and residencies. And I see comments from residents and medical students who are saying, I was on my surgery rotation and I got bumped out of these procedures because I had to have an APP had to do them.
Oh.
I mean, surgery residents who aren't getting to do intubations or aren't getting to do lines because they have to defer them. That's also very bad. I mean, it isn't that we don't want these folks to learn how to do those things, but ultimately, in the ICU, should the APP be the person overnight in a residency? No, it should be a surgery resident, internal medicine resident. It should be somebody who's there to learn and do those things. But I mean, that's what I think. I mean, I had a friend whose wife just graduated with her nurse practitioner, and she was almost immediately hired as the overnight ICU hospitalist at a large center. And so she was learning to do her lines and things. I think that's problematic. I do think that we need to make sure we're sensitive and kind to the people who are doing this, and many of them, again, are very compassionate, good people who know what they're doing, but they have to have limitations. And look, I'm afraid when I go to work. I think if you're a smart doctor, you have a little anxiety. Every time I intubate somebody, I'm anxious, and I've done it untold times. Every time I put a chest tube in, I'm anxious, and I should be. Every resuscitation, I'm anxious. That's because I know what I don't know, right? You know, I would never presume to know what a surgeon knows or anything else.
Of course not. Yeah, and you just made me think of something too. In the case of the nurse practitioner who just graduated, it's like, who made the decision to hire her,
right,
and put her in that position too? Shame on that person as well.
Right.
It's like, this to me reflects a total lack of understanding or comprehension of what the job really entails, and yet you're going to throw this person into this, and it's just a disaster waiting to happen. Hopefully it won't be.
Here's the great irony. Kids aren't allowed to moonlight anymore like they used to.
Right.
So, you know, in years past, you take a surgery resident and who's moonlighting and put them in the surgical ICU overnight when they're a third or fourth year resident, and they'd be awesome, right? But now we say, well, we can't do that. They haven't finished training yet. I'm sorry, what? I'm not a surgeon. If you're a third year resident, have you done a lot of cases? Of course you have, right? By third year of surgery residency, you've done a lot of cases, right, guys?
Yeah.
Absolutely.
Correct.
Yeah.
So, I mean, why can't that person do this? I mean, I can't, and furthermore, I can't go and be an intensivist. The pathway's closed for emergency medicine. But you can use that person, a PA or somebody, to do that. I can't be an orthopedic surgeon, but an orthopedic surgery group will hire someone who's a PA to round for them, and they'll make pretty good money. Well, I'm not sure I understand that. I mean, we work under these constraints in our boards, but those are becoming irrelevant, and people are recognizing that. And that they're upset about this because, like, look, I thought my board guaranteed that I was a specialist in this, and now that's becoming questionable. I think the medical schools and residency directors should be all over this issue, and they aren't.
And again, it's like, who is calling these shots? Who's making these decisions ultimately? And I keep thinking back, you know, in the hospital sense, you know, we're going back to the administrators, the increased number of administrators, the business. It's the business of medicine that's really at work here. And you know, when I threw out the word commodity earlier, I really meant it. That's really what we are. And, you know,
I told the guys that I got real involved with all the social media stuff with all this. And the one that I have always felt with the newly trained physicians and stuff is if you go on Twitter, the fear is palpable.
Yeah.
I mean, it's palpable.
Sure.
I mean, I was when I first came out of training, I'll admit I learned more in that first 12 months than I learned in 7 years of training.
Right.
Of course.
Because now you're the surgeon, not the guy that his name goes on the chart. But still, I mean, I feel for the young physicians, and you know, that's another.
Yeah. It's like setting up to succeed or setting up to fail, and this is, you know, there's a lot going on here. And, you know, as far as, you know, today's discussion, I think this has been really an important one to have. This is really the state of things, and we're kind of winding down on our time here. So, you know, I'd like to give everybody a little chance to maybe make one last comment or one last thought to throw out there. And Ed, since you are a guest today, I'll just give you 30 seconds to kind of put a bow on this.
What I would say is medical school matters, and it matters because it's a unique and rigorous way to train physicians. Maybe it needs to be changed, and maybe it needs to be adjusted for the times, but to take it and simply throw it off to the side because there are better ways to do it that are untried and untested and unproven, I think that's perilous to everyone. And I think that administrators and clinicians owe it to our patients and to our colleagues and to the APPs to take seriously the difference between medical school and other pathways. Not to denigrate the others, but to say this is really important.
Yeah, well stated. Dr. Cook, I'm going to throw it to you.
I guess, Des, I'll just kind of restate what I was saying before, and that is clearly the tools and knowledge and capability that we have available to us in all areas of medical practice, whether it be physicians, nurses, PAs, nurse practitioners, whatever, is in a state of change. And it appears to me that the most important thing to do right now is, number one, make an objectively evaluated decision about what constitutes proper training to do certain things, and then make sure that the people that are going to do those things have met a certain standard of excellence, been properly examined before they go and do these things. The fact that the amount of experience and the amount of hours that are required to become a nurse practitioner is highly variable from one training program to the other. And that needs to be standardized. It needs to be looked at objectively, and it needs to be fixed, because the mid-level practitioners, or whatever they're going to be called, are necessary. We have to have them. But their training has to be better defined, and their responsibilities have to be better defined.
Well stated again, Randy. Thank you for that. And thank you for bringing Shakespeare into this today, too. I'm usually more along the lines of the Three Stooges or a Seinfeld quote, so I appreciate that. Dr. Z, anything to add to this?
Well, I'd just make a quick refrain, because along what Ed said, I think be careful what you wish for with, here we are Zooming and online medical education. As I told you guys in a previous episode, where they were training nurses in the clinical years in Michigan to do heart lung exams this way. And I just think that somewhere you always have to be able to touch a person. In sales, you got to touch them at least one time. In medicine, you got to touch them every time. And that's my feeling about online.
I love that point. And, in medicine, not only do you have to touch them, but we know as physicians, it's been stated that we have to hear something at least 7 times before it sinks in. So there's a lot to be said for that clinical experience, and not just online stuff. Ed brought it up earlier. Online stuff, it's got a place, but good Lord, you learn so much. Like you guys were all saying, that first year out, that's when you really start to become a doc. Up until then, it's just like child's play, really.
That's true.
Rhonda, in the middle of your sip, of course, it's like you're at the dentist. How's everything? Anything you wanted to add to this?
Yeah, actually, I think everyone has made some very good points, but three kind of stick out for me, coming from the nurse perspective as well as the nurse administrator, because I've sat in the administrator's seat as well, is we need to clearly define the lanes. You can't practice effectively, you can't be competent unless you know what your boundaries are. So we need to define what those are. Number 2, don't let the economics be the only thing that drives the decisions. The best advice I can give an administrator is embrace your physicians and bring them into the business discussions. That will be a huge help in defining what the lanes are and helping to set those boundaries appropriately and effectively and safely. And then thirdly, all of these decisions need to keep the patient at the center of everything we do, everything we talk about, everything that we act upon. You can't make a decision without keeping them in the equation.
Outstanding. Really communication, keeping the patient first and foremost, and all this should always be the what drives us. And unfortunately, I think we have gotten away from that in many instances because of the business of medicine. Well, I think this has been an outstanding discussion today. Really, we kind of bared our souls on some areas too, and sometimes it's not pleasant to have to kind of be blunt about things, but I think we've covered some important areas and maybe even offered some solutions in the process today too. I really appreciate what you guys and Rhonda, our lady, have brought to this discussion today.
Guys,
Just
works
for the
for me
guys.
too. That's right.
Exactly, but I would again also like to thank our very special guest, Dr. Edwin Leap, who added much to this discussion today. You can check out his website. It's edwinleap.com. There's so much great information and great thoughts there too. So I highly recommend that you check that out. And we also would love, you're welcome. It's really been a pleasure. Thank you for being part of this today. And
great fun.
Good. Well, and that's what we want it to be, because inside the lounge, we like to have fun too. Some days it's more serious. Other days we'll cut up a little bit more.
Sure.
But the point is, again, this is a place where we can just kind of let our hair hang down. And my wife said last night as she was cutting my hair, honey, I think you got less hair than I'm working with every time.
Ouch.
I go, well, that's how it goes. But really, inside the Doctor's Lounge, we hope you enjoy sharing, our discussions and being part of it. We hope that you will continue to be part of this. And if you're interested, please send some topic ideas. We would love to have you as a guest too. Tell your friends about it. Tell your colleagues. That's what we're here for. It's the exchange of ideas and thoughts. And again, you get to hear what goes on inside of our crazy minds, but also really there's a lot of experience here too. And we're here for you. Like we all like to always say with MD coaches, we see you, we're here for you, and we believe in you. So until next time inside the Doctor's Lounge, for my colleagues, Dr. Randy Cook, Dr. Rick Zollander, Dr. Rhonda Crow, I'm Dr. Desmond Bell, and again, thanks to Ed Leap. Until next time.
Over the past few years in medicine, we've seen an increase in the number of advanced practitioners, whether they be physician's assistants or nurse practitioners. This trend has continued to the point where doctors are starting to feel more and more expendable. This is not just an opinion, this is reality. So inside the Doctor's Lounge today, my colleagues, Doctors Randy Cook, Rick Zollander, and Rhonda Crow, the CEO of MD Coaches, and I, we're joined by Dr. Edwin Leap, a emergency department physician of over 24 years who also wears many hats, including that of a writer. We were discussing the impact that this flood of some people call mid-levels, others refer to as advanced practitioners, has meant to medicine, the good, the bad, and the potential for some disasters that we see. Anyway, the discussion today was certainly intriguing, and we hope you enjoyed it. We'd love to hear from you. On the screen there, you see that little bell. Please ring that. We would love to get your feedback, and also if you have suggestions for future topics of Inside the Doctor's Lounge, please send them our way. We'd love to have you as a potential guest on the show. Again, Inside the Doctor's Lounge, it's a place where we can all come together and have honest and frank discussion. No holds barred, complete honesty, and no fear of repercussion, just like inside a real doctor's lounge. So we hope you've enjoyed this experience today, and remember, for MD Coaches, we see you, we believe in you, and we're here for you.